In this section, Other Neurotransmitters and Eicosanoids, we will be discussing histamine, serotonin, and the products of the arachidonic acid pathway. In this section, we'll be talking about the pharmacology of other neurotransmitters as well as the eicosanoid pathways. Histamine is a very important chemical that's present in the human body. It's an autocoid, which is defined basically as an eicosanoid that is released from one cell and is bound to another cell very close to where the chemical was released. Therefore, it has properties that are localized. Autocoids generally, such as histamine, cause inflammatory responses. Histamine is present at high levels in the lungs, the skin, and the GI tract. It's released by cells known as mast cells, following certain types of allergic reactions, such as type 1 hypersensitivity reactions. Certain drugs can cause release of histamine. For example, vancomycin causes red man syndrome because of the release of histamine. It's not technically an allergic response, but simply a body response to the vancomycin itself that causes simple release of histamine. Other venoms and trauma can cause release of histamine as well. The histamine receptors are G-protein coupled. H1 receptors, which are found throughout the body, can cause capillary dilation, decreased blood pressure, smooth muscle contraction, especially in the bronchioles, as well as pain and pruritus. All of these together generally are defined as anaphylaxis. H1 antagonists are widely used to treat a number of problems, especially allergic reactions. Patients that have hay fever, urticaria, or rhinitis, or localized allergic reactions respond very well to H1 antagonists. They can also be used for the treatment of motion sickness, and also are used sometimes as sleeping pills. They're available over the counter. H1 antagonists are divided into first-generation and second-generation agents. The prototype first-generation agent is able to penetrate into the CNS, or the central nervous system, and is therefore sedating. The prototype medication is diphenhydramine, which is also known as Benadryl. Hydroxyzine is another H1 blocker that is commonly used, especially in the hospital. It is stronger and causes more sedating. The second-generation agents are sort of a breakthrough in histamine blocking technology and generally are thought to be non-sedating, but are able to prevent the peripheral allergies that we see sometimes. The prototype medication is Zyrtec or cetirizine. Loratadine is another medication that came about that is more popular. Both of these medications control allergies well without sedating the patient as much as the first-generation agents. And this is because they do not penetrate into the central nervous system. H2 blockers are drugs that are very important in the release, on the blocking the release of gastric acid. H2 receptors are found on parietal cells. Therefore, H2 blockers are able to block the release of gastric acid from the parietal cell. H2 receptor antagonists are used for management of mild gastroesophageal reflux disease. And these medications include cimetidine, ranitidine, and famotidine. Generally, these medications are thought to be safe. However, we all know that cimetidine is an inhibitor of cytochrome P450 enzymes. This is a classic boards question, and it can cause multiple drug-drug interactions. Serotonin, which is a very important neurotransmitter, and we will talk about more in the psychiatric medication section, is stored in many different types of cells, including neurons, platelets, and GI cells. Remember also that it's metabolized by MAO type A. Carcinoid tumors are cancers commonly found in the gastrointestinal tract that release 5-HT, 5-hydroxytryptamine, also known as serotonin. The diagnosis of a carcinoid tumor is aided by assays for metabolites such as 5-HIAA, or 5-hydroxyindoleacetic acid, which is a breakdown product of serotonin. Not all carcinoid tumors will release serotonin. However, an increase in the 24-hour urine 5-HIAA is diagnostic for a carcinoid tumor in a patient that also has an abdominal mass. In order to treat the symptoms seen by carcinoid tumors, we can give octreotide, which is an analog of somatostatin. Somatostatin receptors are usually expressed on carcinoid tumors and have an inhibitory effect when activated. Octreotide can actually cause carcinoid tumors to shrink and release less serotonin, which will decrease symptoms that you see in patients that have carcinoid tumors. And those symptoms include flushing and increased blood pressure and tachycardia. Serotonin receptors are numerous and have confusing nomenclature. As of right now, we know of 7 receptor subtype families, and all of them are G-protein coupled, except for the 5-HT3 receptor. This is a ligand-gated ion channel. We'll talk more about this when we talk about anti-nausea medications. Some important drugs that affect the serotonin system include the SSRIs. These selective serotonin reuptake inhibitors will inhibit the serotonin transporter and raise the serotonin levels throughout the brain because they block the ability of the serotonin to leave the synaptic cleft. This increases the concentration of serotonin in the synaptic cleft. These medications include fluoxetine, sertraline, and paroxetine, and they're widely used to treat not only depression, but also phobias, OCD, and tobacco dependence. The side effects of these medications are very important, however. They have been shown in recent studies to increase suicidality, especially in young children and adults. They can also cause decreased libido, and when these medications, SSRIs, are given in concert with tricyclic antidepressants and monoamine oxidase inhibitors, they can precipitate serotonin syndrome. Buspirone is a 5-HT1A partial agonist, and it's used primarily to treat anxiety attacks. Risperidone and clozapine are 5-HT2 antagonists, and they're used to treat schizophrenia. These are part of the atypical antipsychotic family. LSD, or lysergic acid diethylamide, was a drug of abuse especially popular in the 60s and 70s that is actually a 5-HT2 receptor agonist. This drug is a very powerful hallucinogen and is similar to other compounds such as mescaline and psilocybin, which are derived from natural sources. Other medications known as the triptans, including sumatriptan and rizatriptan, are commonly given for migraine headaches. These are 5-HT1D receptor agonists. They actually can cause cerebral vasoconstriction. It's thought that migraines result from a vasodilation in the brain, and therefore any medication that can cause cerebral vasoconstriction would improve migraine headaches. These medications are pretty safe. They can cause sulfhemoglobinemia, which is a condition that usually reverses itself very well. Patients that have sulfhemoglobinemia can have actually a change in the color of their blood from red to more of a brownish color. After stopping the medication, this condition usually goes away. The ergot alkaloids, which have action at serotonin receptor, include the medication ergotamine, which is also used to treat migraines. Ergot alkaloids are precursors to LSD, and they can cause vasoconstriction through binding of multiple serotonin receptors. Ondansetron, which is a nausea-vomiting agent, also known as Zofran, is a 5-HT3 receptor, again, which is an ion channel antagonist. This medication is used in the treatment of chemotherapy-induced nausea and vomiting. It's thought that it works through the area postrema in the brain. This medication is sort of a breakthrough in nausea control. However, it's very important to watch these patients' EKG, as ondansetron and zenestratron, a related compound, can cause QT interval prolongation, which can lead to torsades. Let's talk about eicosanoids. Eicosanoids are lipid-derived autocoids, which means that they are locally acting mediators. Autocoids, by definition, usually are seen in sort of a paracrine manner, meaning they work locally. They're not transmitted through the bloodstream. And eicosanoids are derived from membrane phospholipids, especially arachidonic acid. They have diverse roles in inflammation and cell signaling and are becoming much more popular today in our ability to understand how the human body works. Eicosanoids include prostaglandins, prostacyclin, or PGI2, leukotrienes, and thromboxane A2. And it's thought that multiple body functions are related to balance between prostacyclins and leukotrienes. Arachidonic acid is a precursor of most of the eicosanoids. Arachidonic acid is synthesized from linoleic acid, which is an essential fatty acid. It has an omega-6 group. And arachidonic acid is released from the membrane of the cell by phospholipase A2, or PLA2. Eicosanoids are generally low in concentration in the body. However, the synthesis of eicosanoids can be upregulated in response to multiple factors, including inflammation, trauma, and certain toxins. This is an overview of how these molecules are created. As you know, the membrane bilayer contains many phospholipids, which are converted by phospholipase A2 to arachidonic acid. Arachidonic acid can then be converted by multiple enzymes, including COX-2 and COX-1, to prostaglandin G2, H2, and then are converted in tissue-specific isomerase fashion to different molecules such as prostacyclin, thromboxane A2, prostaglandin D2, E2, and F2. And all of these compounds have different roles downstream. Prostaglandins are formed by COX enzymes, which are also known as cyclooxygenases, and also known as prostaglandin synthase enzymes. Let's talk about the COX enzymes. COX-1 is expressed in most tissues, and it's constitutive, meaning it's always there. It's generally not inducible by stress. COX-1 is very important for protection of gastric mucosa and to maintain vascular homeostasis. COX-2, however, is expressed in the brain and the kidney and at certain sites of inflammation, and it has an inducible expression, meaning that as inflammation goes up, the COX-2 level and the COX-2 activity in the body will increase approximately 20 to 80-fold in response to certain stimulations such as TNF-alpha and inflammatory cytokines and LPS, or lipopolysaccharide. Prostaglandins will encompass a large family of molecules. They have very confusing nomenclature, but the most important prostaglandins that you should know for the test involve the PG series and the PGH2 series. PGD2, or prostaglandin D2, is produced by mast cells and causes smooth muscle contraction and bronchoconstriction. PGE2 is very commonly seen throughout the body. It's responsible for protecting the gastric mucosa. It's responsible for causing uterine contraction, and it can actually cause a fever. Prostaglandin F2 is produced by both vascular and uterine smooth muscle, and it can induce an abortion. Thromboxane A2 is very commonly produced in platelets as part of the COX-1 pathway. Thromboxane A2 is thought to be a very strong vasoconstrictor and is also a promoter of platelet adhesion and aggregation. When you have a blood vessel that has a blood clot associated with it, the blood clot has multiple platelets in it that will release thromboxane A2. And that thromboxane A2 will cause a vasoconstriction. The point of this vasoconstriction is to help block this artery in order to prevent bleeding. Prostacyclin, or PGI2, is a product of the vascular endothelium in the COX-2 pathway. It is an opposite of thromboxane A2 because it causes vasodilation and it inhibits platelet aggregation. Thromboxane A2 is thought to be stronger than PGI2, however. The homeostasis between these two molecules is thought to be very important. This balance between thromboxane A2 and PGI2 can be altered by COX-2 inhibition. Blocking COX-2 causes excess of thromboxane A2, which is a COX-1 product. This is a possible cause of the cardiac side effects that we see in Vioxx or rofecoxib and other COX-2 specific drugs. As you may be aware, there was some recent controversy regarding these COX-2 specific molecules. Let's talk about NSAIDs, or non-steroidal anti-inflammatory drugs. The prototype NSAID was aspirin. There are other NSAIDs that we commonly use. ibuprofen, naproxen, and indomethacin. Traditional NSAIDs are non-selective again. They can inhibit COX-1 and COX-2. Most of what we see in terms of anti-inflammatory effects in NSAIDs are related to COX-2 inhibition. This is an overview of the arachidonic acid pathways again. Most importantly, look at the side that's related to the COX enzymes and the 5-lipoxygenase pathways. You can see that the COX enzymes are inhibited by the NSAIDs, and that will prevent production of prostaglandin G2 and H2, which will prevent production of thromboxane A2 as well as prostacyclin. But will promote the production of leukotrienes. Now, leukotrienes have been shown to cause vasoconstriction, bronchospasm, and increased permeability. So blockage of the COX enzymes can actually cause symptoms related to that. Aspirin, or acetylsalicylic acid, is an old medication but still very important today. It's the only clinically marketed irreversible or suicide inhibitor of both cyclooxygenase 1 and cyclooxygenase 2. It has multiple actions that we use it for, including platelet inhibition. It can reduce pain, it can reduce fever, and it has anti-inflammatory effects. In general, patients do not take aspirin for pain as much as they used to. Aspirin works by inhibiting COX-1 and only partially inhibiting COX-2. Inhibition of COX-1 will prevent platelets from making thromboxane A2. Therefore, platelets that have been inhibited by aspirin are completely inhibited, and the body must make new platelets in order to overcome the aspirin effect. This shifts the balance towards prostacyclin, which causes vasodilation and antithrombogenesis. A daily baby aspirin, which is 81 milligrams, has been shown to prevent myocardial infarction and stroke. This cartoon shows, as we age, how our blood vessels change. In general, it's thought that around age 40 or 50, the risk increases for development of a complicated plaque in the blood vessel. You can see here how the fatty streak evolves into a fibrous plaque as atherosclerosis evolves. And as that plaque gets bigger and bigger, we run more and more of a chance of plaque rupture. And plaque rupture is what is thought to cause, along with thrombosis, to cause acute coronary syndrome, or ACS, which is the major cause of ST elevation MI, or myocardial infarction from ST elevation. Therefore, it's very important in these patients that have atherosclerosis and coronary artery disease that we control their platelet aggregation with aspirin, ASA, acetylsalicylic acid. Salicylates are also very important for the treatment of inflammatory bowel disease. Salicylates are given as an oral preparation or an enema preparation. They work intraluminally or intragut to prevent the production of inflammatory mediators in the gut, which is how they generally work. The most commonly given salicylate in ulcerative colitis and Crohn's is sulfasalazine. Other medications that are used in ulcerative colitis and Crohn's disease would be 6-mercaptopurine and infliximab, medications that we'll talk about more in the immunopharmacology lectures. As you can see here, sulfasalazine, which is a large molecule, is broken down in the colon by bacteria to release the active salicylate agent, 5-aminosalicylic acid. It also releases a compound, sulfapyridine. Some adverse effects of aspirin which you should know about mostly include risk of bleeding and ulceration. Because aspirin blocks COX-2, you can see GI ulcers and bleeding. You can also see middle ear effects and inner ear effects from aspirin, including tinnitus and vertigo. Bronchoconstriction can also occur because of what we talked about before, blockage of the COX-2 pathway. 10% of asthma patients are thought to have overactivation of the leukotriene pathways. Reye's syndrome is seen in pediatric patients that have a viral syndrome that take aspirin, which is a neurohepatic encephalopathy. Some bleeding complications can occur from aspirin. And aspirin can also cause increased metabolic rate, causing hyperthermia. This is a photograph of an endoscopic view of an ulcer. You can see the ulcer bed here. And this is normal gastric mucosa around it. And you can see an enteric-coated aspirin right here sitting in the gastric ulcer. This is supposed to be comical, but it can show how bad gastric ulcers can be and how even an enteric-coated aspirin, an aspirin that's not supposed to bind in the gut or in the stomach, can worsen peptic ulcer disease. Patients that overdose on aspirin will actually develop an acid-base disorder that's mixed. Even though aspirin itself, acetylsalicylic acid, is a weak acid, aspirin itself has a direct stimulatory effect on the breathing center in the brainstem. As you would guess, when a patient has a metabolic acidosis, that patient will be stimulated by the kidneys and by the brainstem to increase the respiratory rate in compensation. However, aspirin not only causes a metabolic acidosis, which may cause an increase in the respiratory rate, but it also directly increases the respiratory rate in the brainstem. It's not clear how that works. Reye's syndrome, again, is a hepatoencephalopathy that is commonly seen when aspirin or other salicylates are given to patients that have either chickenpox or the flu B infection. In general, we should not give salicylates to any children, and they should not be used by breastfeeding mothers. Other NSAIDs that we've briefly talked about so far include ibuprofen, naproxen, and indomethacin. These are used for pain control. They can be used to lower fevers and can have anti-inflammatory actions. They're very commonly given for arthritis. These medications do not work very well for antiplatelet effects. Aspirin is much better at blocking platelets than these. Ibuprofen, also known as Motrin or Advil, is very commonly used for arthritis, gout, and it can be used for dysmenorrhea as well. Naproxen works longer, only has to be given once or twice per day, and it has less GI effects than aspirin. It's become more popular lately. Briefly, we'll talk about the selective COX-2 inhibitors. These medications inhibit COX-2 more potently than they inhibit COX-1. The prototype medication was celecoxib, also known as Celebrex. Rofecoxib was subsequently introduced, and meloxicam was introduced after that. Patients that have gastric ulcers plus arthritis are commonly given these medications to treat the arthritis. COX-2 inhibitors are able to treat pain and cause anti-inflammatory effects without worsening gastric ulcers in general. It's important to remember, though, these are the COX-2 selective medications, including rofecoxib. These medications are able to block COX-2 about 5 to 50-fold better than COX-1. However, they do still block COX-1. Rofecoxib, or Vioxx, was taken off the market in the United States because of negative cardiac effect risk profiles. Again, even though they were heavily marketed, concerns in 2002 and 2004 began to surface about the effects of COX-2, especially on the cardiovascular system. Rofecoxib, as you can see on the top curve, in the VIGOR trial, showed an increased risk profile as compared to naproxen or Aleve over time, especially at 12 months. It was shown that patients that were taking Vioxx had increased risk of stroke and heart disease. It showed that patients taking rofecoxib had a 3.5% risk versus placebo 1.9%. And it's unclear if these risks are related to the entire class of drugs, the entire COX-2 inhibitor class, but it's also true that rofecoxib itself is the most selective COX-2 inhibitor, very selective. So it may not apply to other medications such as celecoxib and meloxicam because they do not block COX-2 as selectively as rofecoxib does. Acetaminophen is not a COX-1 or COX-2 inhibitor, but it is an analgesic and an antipyretic. It's also known as Tylenol. Its mechanism of action is pretty much unknown, and it's not anti-inflammatory. It's thought to work in the hypothalamus. The difference between acetaminophen and NSAIDs, again, it does not have an anti-inflammatory effect. It does not inhibit platelets. It's not as implicated in Reye's syndrome. There are some reports that acetaminophen can cause Reye's syndrome, and it also does not cause bronchospasm as much as other NSAIDs do. Acetaminophen is one of the most commonly taken medications in the United States because it's available over the counter. The problem with acetaminophen is that it can really cause overdose problems that can be disastrous. Acetaminophen overdose is the major cause of liver failure, causing death or requiring liver transplant, particularly in teenagers and young adults. An acetaminophen overdose can be really worsened by concomitant alcohol use. Acetaminophen metabolism is complicated, but it's metabolized mainly by the liver glucuronidase transferase to form an inactive conjugate. And this is a safe molecule that is easily released by the body into the urine. However, there is a cytochrome-dependent pathway that produces NAPQI, or N-acetyl-parabenzoquinonamine, which is a toxic reactive metabolite that the body needs to deactivate by glutathione. NAPQI is toxic to the liver. And you can see here NAPQI, which is a breakdown product of Tylenol, by the cytochrome pathway. Normally, a Tylenol or acetaminophen here is broken down in a safe pathway, either by sulfation or glucuronidation. In order to rid the body of NAPQI, the body needs a fresh supply of glutathione, which is why we give reducing agents such as N-acetylcysteine to patients that have acetaminophen overdose. NAPQI is toxic because it's able to covalently bind to cell proteins. In a serious acetaminophen overdose, again, glutathione levels become depleted. The NAPQI molecule can damage hepatocytes, and it can cause necrosis and liver failure. With regard to alcohol in acetaminophen, the chronic use of alcohol will enhance liver toxicity because cytochrome P2E1 is upregulated in these patients. However, patients that drink alcohol acutely but not chronically, along with taking lots of acetaminophen, are actually protected against liver toxicity because they compete for the same enzyme. The antidote for acetaminophen overdose is N-acetylcysteine or mucimist. It's very important that you remember this for step 1. The way this works is by replenishing the storage of glutathione in the hepatocyte. And it has to be used within the first 12 hours before the damage to the liver becomes irreversible. Another very important drug that used to be given more approximately 10 to 20 years ago is Cytotec, also known as misoprostol. Misoprostol is a prostaglandin E1 analog that is used to protect the mucosa of the stomach. And it can either be given along with NSAIDs, or it can be given after a patient has developed an ulcer related to an NSAID. Misoprostol is also commonly given to induce abortion in conjunction with the abortion pill RU486. Mifepristone itself interferes with progesterone on the developing fetus, and misoprostol is able to cause uterine contractions and induce abortion. Prostaglandin E1 is also known as alprostadil, and this medication can be used in a newborn to maintain a patent ductus arteriosus in certain cardiac conditions. That includes transposition, coarctation, valvular atresia. It can be used in both cyanotic and non-cyanotic cardiac conditions. After the repair is done to the heart, then it is discontinued. It can also be used to treat erectile dysfunction. Prostaglandin E2, or dinoprostone, is generally used to progress labor by inducing uterine smooth muscle contraction. Many prostaglandins, not only E2, can cause uterine contractions. We've talked about leukotrienes before. Let's talk more in detail now. Leukotrienes are eicosanoids that are formed by the 5-lipoxygenase pathway. Leukotriene B4 is very important for inflammation, whereas leukotriene A4, C4, and D4 can also cause anaphylaxis and bronchoconstriction. Aspirin-induced asthma, as we talked about before, is likely a result of shunting arachidonic acid away from the COX enzymes towards the 5-lipoxygenase pathway, which can cause anaphylaxis and bronchoconstriction. So therefore, it's not a true asthma. It's not a true allergy. Other medications that are very important in the leukotriene pathways include montelukast and zafirlukast. These medications are newer, and they are antagonists at the leukotriene receptors. They work by inhibiting bronchoconstriction. They have been more commonly given not only to patients with environmental allergies, but also patients with asthma. They do not work in all patients, however. We'll talk more about these medications in the pulmonary lectures. They have been shown also to cause GI distress and are linked to Church-Strauss syndrome or hypereosinophilia. This is the last slide in this section. This concludes our lectures on the autonomic nervous system. Next, we'll be going over some questions about the autonomics. This concludes our lectures on the autonomic nervous system. Next, we'll be going over some questions about the autonomics.